So I think the trials are going to be positive. I think that they may not be positive by meeting pre-specified endpoints, but they're going to demonstrate enough significant clinical activity that anybody who's sentient will be able to figure out that there's enough germ of truth there to move forward.
Yeah, and I don't disagree with that.
And I also think that the next, I don't know which ASCO it's going to be, whether it's ASCO 2015, 17, 18, or 20, we're going to be having a revolution in the way we think because of the impact of these checkpoint inhibitors and all the other immunotherapy vehicles that are coming down the pike, where we're going to start thinking about not what you were saying, Omid, about having consolidation of chemotherapy gains with immunotherapy, but where the immunotherapy will be the accepted strategy for giving a curative option, and we'll be using chemotherapy or targeted therapies or surgery as sort of adjuvants, if you will, to help us achieve that cure more effectively. Because I think that's really where we're heading.
Absolutely.
And I think that we need to do that in lung cancer. Because we had a presentation today with in the chemoradiotherapy strategy that was the same old. The bar's not moved at all. That's an opportunity.
Well, there's a trial. Actually, I think MedImmune AstraZeneca announced a trial, a phase 3 trial in that very setting, using their PD-L1 agent.
I think Roy will agree with me. We've kind of maxed out our chemoradiotherapy strategies, and we're kind of at a plateau. We need a new paradigm in that population. I think that trial is very timely.
And that's interesting because that's, you can cure lung cancer.
Yeah.
And that's a setting where you have 15, 20% patients cured. We really have a lot of opportunity, and that bar hasn't moved very much.
Right. Not at all.
Despite a lot of new radiation techniques, new drugs, but something like this could really help.
Yeah,
I agree. So are there any other clinical trials that are employing immunomodulatory strategies in lung cancer that you guys are excited about?
I think we've talked a lot about paradigms that I think apply to most of the population we see. The 80% of patients that don't have an oncogenic driver, that typically are the smoking population. We touched a little bit on the kind of the molecular mayhem that's going on in those patients, and maybe that's an advantage for these sorts of things. I think we alluded a little bit to the special populations of defined oncogenic drivers. And I think trials in that, although they'll take much longer to kind of read out and get a sense of, but as thrilled as we are with the TKIs we have available for a number of molecularly defined subsets, the reality is that 9 to 12 months these patients are progressing.
Right.
And we need to kind of rethink that. We do have some, very nice data with subsequent generations of TKIs, second generation of ALK inhibitors, and those sorts of things. That, but again, I mean, we have a ceiling there that we need to kind of think out of the box. And I think integrating immunotherapeutic approaches in that setting is an area that should be of intense interest.
So as we think about the use of these kinds of strategies, we're actually ignoring to some degree the sort of flip side of the record, which is trying to activate the body's immune system to attack cancer. And as you know, that was the major strategy employed in the field of tumor immunology over the past 40 years or so. And whether it was vaccines or interleukin-2 or certain kinds of antibodies, that's really been the idea. It hasn't been about attacking the tumor component as much in terms of how the tumor defends itself, as much as trying to just blast through the defenses by supercharging the immune system. And CARs and tumor infiltrating lymphocytes that have been pre-selected are certainly enjoying a period of great interest and some really remarkable findings in some malignancies. Do you see a role for these kinds of strategies in your respective malignancies as we move forward, or do you think the toxicity profiles are going to be too daunting for near-term applications?
A couple of questions there. Certainly the CARs, we've talked about CARs for lung cancer. The question is, what antigen would you use? I know a number of groups have started to look at that. Certainly that would be an interesting approach. Some of the combinations we talked about earlier, I think, should be studied in lung cancer. We might need a little bit more work on a nivolumab, ipilimumab combination in lung cancer because of toxicity concerns. Also, as things move from one center to other centers, as we talked about. But there are other agents, tremelimumab and others, that might combine better. And I think we'll see some of those combinations We'll see combinations with vaccines. There are some vaccines that have shown some activity in lung cancer, and there is some early data to suggest that that could enhance the T-cell infiltrate. Epigenetic approaches, the group at Hopkins has pioneered some of that. So there are ways to sort of think about how to, as you say, enhance the immune system. The thing that I worry about, though, is some of the combinations you see, I wonder what you think about this. People are combining agents like a PI3 kinase inhibitor with a nivolumab or with an immune approach, and you wonder what effect are those agents going to have on the T cell, too. So it makes me worry sometimes.
Well, I think that's a fair comment. I mean, you always have to beware the dark side of the force when you do these kinds of combinations, don't you? And I worry about it in two different ways. One is that you have to also look at the, as you correctly point out, at the immune regulatory apparatus and ask whether or not adding these signaling inhibitors is actually blocking that which you're trying to accomplish. But there are also these unsuspected toxicities that emerge when we do combinations, like the whole vemurafenib-based combinations with IPI, right, where there was a lot of toxicity. But at the same time, if you do it carefully, you can actually learn some interesting things. For example, there was a study done in melanoma that we participated in at Georgetown, where patients were treated with vemurafenib and then underwent biopsies of their tumors at defined time points after initiation of therapy, and you could see that as these lesions were beginning to respond, there were sheets of T cells that were appearing in the tumors. Now, that's a biology that's tractable. We need to understand how to now take advantage of that in a way that we'll be able to get the benefit of blocking a checkpoint at the same time we're causing this influx of T cells without having these synergistic toxicities. And that may require sequencing, for example. So there's a lot of opportunities like that.
That idea of timing is so important because just like Jen Wargo and others have presented that there's a T cell infiltrate.
Right.
If you wait too long, then that T cell infiltrate is not as strong.
Precisely.
And for all oncologists accruing to clinical trials and for patients coming, I think that underscores the importance of getting biopsies, the importance of being rigorous in asking for those consents when it's time.
I agree. So, gentlemen, thank you. This has been just a great discussion. We've reviewed a lot of information about the latest clinical advances in antibody-based cancer immunotherapy. And to close, I'd like to thank the panelists from today's discussion, Rob Dreiser, Omid Hamid, Roy Herbst, and Mark Sosinski. And on behalf of our panel, we thank you for joining us, and we hope you have found this peer exchange discussion to be useful and informative. Thank you.